Everyday language relies heavily on gravity and observer perspective. If you tell a surgeon to operate on the top of an organ, that target location changes entirely depending on whether the patient is standing up, lying flat on a table, or inverted in a surgical chair. Subjective terms introduce spatial ambiguity, and in medicine, spatial ambiguity is dangerous. To eliminate observer bias, medical professionals discard everyday directional language. They rely instead on a standardized zero-tolerance spatial framework. The foundation of this framework is anatomical position. It serves as the universal zero point, the exact origin of a human coordinate system. This origin point demands strict geometric parameters. The body is erect, facing forward. The arms hang straight at the sides, with the palms facing fully forward, and the feet are positioned slightly apart, toes pointing straight ahead. Anatomical terminology provides the geometric framework required to map three-dimensional biological space with absolute precision. Within this biological space, directional terms function as mathematical vectors. They never exist in isolation. They map a structure's position strictly relative to another structure or back to the origin point itself. The vertical axis is mapped using the terms superior and inferior. These operate exclusively along the cranial to caudal line, meaning toward the head or toward the tail. The nose is always superior to the mouth, regardless of the patient's physical posture. The horizontal axis is defined by proximity to the body's absolute midline. Structures closer to this center axis are medial, while those situated further out toward the sides are lateral. This basic XY logic breaks down on the limbs, which possess high rotational mobility. For the appendicular skeleton, we use proximal and distal. Proximal vectors pull toward the point of attachment at the shoulder or hip, while distal vectors push further away toward the fingers and toes. The surface of this coordinate system is further divided into distinct regional zones. Terms like cephalic for the head, cervical for the neck, or thoracic for the chest act as defined geographic patches on the body's exterior. By combining relational vectors and regional zones, clinicians completely remove their own physical perspective from a diagnosis. They can precisely plot the coordinates of a pathology so that any other practitioner can find it instantly. Observing internal architecture without physical destruction requires translating complex three-dimensional volumes into flat, two-dimensional cross-sections. This translation relies on three primary planes of section. The sagittal plane slices parallel to the body's longitudinal axis, dividing the form into right and left portions. A perfect bisection straight down the midline is a mid-sagittal section. Shifting that slice off-center creates a parasagittal section, resulting in unequal left and right halves. Rotating the slice 90 degrees gives us the frontal or coronal plane. This divides the body entirely into anterior or front and posterior or back sections. The transverse plane creates a true cross-section. It cuts perpendicular to the longitudinal axis, cleanly separating the superior from the inferior. Diagnostic tools like MRI and CT scanners do not display native three-dimensional space. They rely entirely on capturing sequences of these standardized planes. Understanding this geometry ensures a transverse scan of a liver is read the exact same way in Tokyo as it is in London. Behind those two-dimensional slices, human internal architecture is organized into nested compartments. These cavities isolate, protect, and support highly specialized organ systems. The dorsal cavity is a rigid, bone-encased vault. It encompasses the cranial and vertebral spaces, heavily fortifying the fragile central nervous system against any external trauma. Opposite this is the dynamic ventral cavity. It houses the organs of the thorax and abdomen, vital structures that are constantly shifting in their overall volume and shape. This anatomical model illustrates the complexity of the anterior torso. The abdominopelvic cavity is a massive, undivided space filled with complex, tightly packed soft tissue. There are no obvious internal dividing lines here to help isolate a specific point of distress. To solve this, anatomists overlay a theoretical grid consisting of 9 specific regions. Sections like the central epigastric or the right hypochondriac regions act as a localized diagnostic map. Because surface regions map precisely over specific underlying organs, clinical communication becomes highly efficient. A physician can physically palpate the right iliac region and immediately suspect appendicitis, long before the patient is loaded into an imaging machine. The dynamic organs inside these cavities introduce an engineering tension. The human chassis houses structures that constantly expand, contract, and beat in extremely tight proximity. Without a physical buffer, this continuous mechanical friction would quickly destroy the surrounding tissue. The biological solution is the serous membrane. These are thin, double-layered sacs separated by a microscopic gap filled with a lubricating, watery fluid. These membranes function as fluid microcompartments. The inner boundary, known as the visceral layer, clings tightly to the organ itself. The outer parietal layer lines the wall of the surrounding cavity. We name these membranes based strictly on their geographic location. The pleura surrounds the lungs. The pericardium encases the heart, and the peritoneum envelops the organs of the abdomen. Serous membranes apply the principles of fluid dynamics to mitigate the constant mechanical wear and tear of simply being alive. We can synthesize this entire framework to define the absolute position of a single biological structure. Take the heart. Tracing its vectors, it sits medial to the lungs and superior to the diaphragm. Following the nested architecture, it is located within the ventral body cavity, deep in a medial subcompartment called the mediastinum, and completely enclosed by the visceral pericardium. Anatomical terminology is a rigorous spatial language, equipping future professionals with the coordinates necessary to navigate the complexity of the human body with zero margin for error.